Moving along, we'll go to Dr. Mahalia Aldea, who is a thoracic medical oncologist at Gustave-Roussy in France. She is also one of our colleagues at Dana-Farber, but is leaving us soon to go back to Gustave-Roussy. However, she is a translational oncologist focused on novel targets, including her expertise in RET, as well as MTAP-deleted tumors. Dr. Aldea.
Thank you, and thank you for this invitation. Happy to be here. Okay, I will talk about some new therapies in RET-rearranged non-small cell lung cancer, and then I will talk about a new target in non-small cell lung cancer called MTAP. And in order to make this more understandable, I will start with a patient case in order to follow its journey and to understand where these therapies could integrate in the patient history. So we have a female of 63 years old without any smoking history that was diagnosed with a stage 4 lung adenocarcinoma. The molecular testing at diagnosis showed that the patient had a RET fusion and also found two other alterations called MTAP deletion and CDKN2A and B deletion. Given the presence of this RET fusion, the patient started a first-line treatment with a selective RET inhibitor, a first-generation selective RET inhibitor called selpercatinib. This is a drug that has FDA approval and EMA approval in the first line and also in later lines in patients with RET fusions based on, in the first line, of a comparison with chemo with or without immunotherapy, which showed significant benefit in progression-free survival with a median of 24 months. Our patient had a benefit for 22 months, but unfortunately after she had progression, and we performed a biopsy at progression, and it was found the same alterations that were initially present, but also a new mutation, this RET G810C, which is what we call a resistant RET mutation, which was acquired under the selecting pressure or selpercatinib, and it's responsible for the reason for which this patient progressed. When we have this resistance to targeted agents, there is three types of big classes of resistance. The first class, where this resistance mutation integrate, is what we called on-target resistance. That means that the target, which was initially blocked, in this case RET, will undergo some changes, sterical conformational changes, changes in shape of the protein. And the protein will not necessarily allow the drug to bind and to inhibit this protein, but it will be more attracted by proteins that are in the tumor environment that are energy proteins called ATP. So this is the first type of resistance. The second would be, even though this does not happen at the protein level of the target that is inhibited, there are other targets that are connected to this protein which start being active, and actually the drug will not necessarily work because it's bypassed by these active pathways that can be downstream or parallel or upstream to our protein of interest. And the third one is this, what we call phenotypic transformation, which is rare. When the histology of the tumor changes, in this case from adenocarcinoma, it could change to another histology called, for instance, in a small cell lung cancer, and the tumor becomes very aggressive and hard to treat. But for this first mechanism of resistance, what we called on-target, there are inhibitors that were developed, which we call the next generation RET inhibitors. And here, if we see in how many cases this type of resistance occurs, this is a study that was presented by Dr. Cooper here present at ASCO 2023, who showed that actually these secondary RET mutations acquired at resistance are present in around 13% of cases. And given that this number is a bit rare, many of these next generation RET inhibitors who were developed to overcome this kind of resistance were not necessarily undergoing a further development because the population was too small. But actually, we have some kind of champion that actually underwent these steps and was presented at ASCO this year. It's called the product EP0031, but now it has a name called lambotinib. This is a phase 1 escalation study, meaning that patients with RET fusion or RET mutation in this case received increasing doses of this drug in order to establish the safety and, of course, to have a signal of efficacy. There were 40 patients that were treated, out of whom 22 had non-small cell lung cancer. And the dose that was selected to be developed in the phase 2 was the 90 milligrams per day. It's an oral drug once per day. What's interesting in this case is that patients had responses also in the treatment-naive setting, but also when they were pre-treated with selective RET inhibitors such as selpercatinib or pralsetinib. The drug has brain activity. We see responses in the few patients that had brain metastases. In general, this kind of next generation inhibitors are designed in order to have brain activity. And in terms of side effects, generally the drug was well tolerated. Patients had some headaches, anemia was observed. There were some lab abnormalities in terms of phosphate levels that were easily managed, and also some kind of eye irritation that is called keratitis. Today, this drug is undergoing evaluation in a larger trial, in a phase 2 trial, which is open in the US and in various sites in Europe. And also, of course, in China. And this drug is currently undergoing investigation either in the first line as a single agent, either as in association with chemotherapy, also in the first line. This is similar to what has been tried also in and successful in patients with EGFR non-small cell lung cancer. And also a third indication is where the patient have already received the first generation RET inhibitor, selpercatinib or pralsetinib, and after they are eligible to receive this next generation RET inhibitor in addition to the chemotherapy. And for us, our case report, where the patient receives selpercatinib, would be eligible, for instance, for this kind of strategy in this phase 2. Let's do not forget that our patient also had another target that was present, which was called the MTAP loss. And here there is a picture because MTAP loss can be detected either by next generation sequencing, either by staining in immunohistochemistry, a staining which uses one single slide of the patient's biopsy. And here we see that this pale color corresponds here to tumor cells that have lost this protein called MTAP. And we see the brown, which is MTAP present in the surrounding of the tumors. And this target is a weakness for the cancer cell. And why is that? So when MTAP is lost, we have an accumulation of a buildup of some proteins called MTA. And this MTA inhibits another protein called PRMT5, which is responsible of silencing certain proteins. And this is partially inhibited. So we imagine that if we have already this weakness, if we add an inhibition of the PRMT5, we will be able to further reduce tumor growth. The first efforts that were made to inhibit this PRMT5 were made with a class of drugs called catalytic PRMT5 inhibitors. And unfortunately, the first examples show that these drugs were limited by hematologic toxicities like anemia, low white blood cells or low platelets, and their development was impaired by this type of toxicity. Further development have tested other type of inhibitors, the MAT2A, and even more the MTA cooperative PRMT5 inhibitors, and this later class is the most advanced. It inhibits both the MTA and the PRMT5, and actually, because of this, it's selective for those cases that really have the loss of MTAP, and we do not see this hematologic toxicity that was previously seen with the first PRMT5 inhibitors that were developed. Where is this target found? So it's not only in non-small cell lung cancer, and actually we have known this target for years in mesothelioma, where it's a marker that is used in the diagnosis of cancers of the pleura. But we did not talk that much about this target because until recently we did not have effective drugs. So today we see that in non-small cell lung cancer, this target is present in around 10-15% of cases. And also what's interesting is that if the patient already has a driver alteration such as ALK, RET, EGFR, ROS, it does not mean that the patient cannot have also this target called MTAP loss. And even more, we have recently reported that these patients, for instance, with ALK, RET, and also EGFR, seems to have even more this presence of this driver called MTAP loss as compared to patients without these alterations. So now we have drugs that reach the early clinical trials, and now they are developing in later, larger clinical trials. So the first examples were the phase 1 reported with 2 drugs developed by Amgen and BMS, and where we saw that in a pan-tumor setting, so not only in non-small cell lung cancer, in more tumor types that had this MTAP loss, there were tumor shrinkages that were present in around 20-30% of cases. So it's not that impressive as compared to a targeted therapy where these tumor shrinkages are very much more important. But what's interesting to see is that despite not having a high tumor shrinkage, these patients may have durable responses. So even with a stable disease. Also, these drugs can work later. These kind of drugs are well tolerated overall. There is a mild gastrointestinal toxicity, and as opposed to the first classes, they do not alter significantly these blood counts. In non-small cell lung cancer, we had a report this year at World Lung of the BMS product, the PRMT5 inhibitor, where in non-small cell lung cancer, we see again an objective response rate, tumor shrinkage in 30% of cases. But again, we see that 1 out of 3 patients did not progress at 6 months. In this plot where each line is an individual patient with a duration of treatment, we see that some of the patients had really long treatment durations. And this is consistent with the fact that despite not having this tumor shrinkage, we can have these responses that might last and even occur later. When we look what happened in patients with oncogene-driven disease, such as those with EGFR or ALK, again, it's surprising to see that, for instance, in EGFR, 4 out of 7 patients had responses. In ALK, 2 out of 4 had responses. And this encourages to really seek these patients and to include them in such trials, because this type of therapies, despite the fact that patients were heavily pretreated in general, seem to have a significant benefit. So I would say in conclusion that we have some new drugs for RET, this next generation RET inhibitor that is paving its way into clinics. We have a new interesting target in non-small cell lung cancer called MTAP, for which we should start screening, if not already started, to screen our patients, and even those that already have an oncogenic driver. And because this type of treatments may offer more benefit and also a chemo-free option. Thank you.